Hey y'all, welcome back. This week we are going to chat about vaginal hormones. So there's not as many options for this. This video is not going to be as long as my video from last week, but tiny bit of overlap. In some patients, I'm not going to say a majority, but in some patients, they may feel that they either don't desire to start systemic estradiol for a personal reason, for a medical reason, what have you. But they may still have genitourinary symptoms, recurrent UTIs, vaginal dryness, pain with intercourse, urinary frequency, irritation, what have you. So in those patients, or in patients who do not feel that they get complete resolution of their genitourinary syndrome symptoms, they may choose to do a vaginal hormone either by itself or in addition to their systemic regimen. So what options do you have if you are choosing a vaginal hormone? The first option is a cream. There's a couple kinds of creams. One I tend to use more than the other, but Premarin and Estrace. Those are the brand names, so obviously there are generics, but Premarin is a conjugated equine estrogen, so it's going to come from pregnant mare urine and have multiple different kinds of estrogens in it, whereas the Estrace is a bioidentical estradiol, and this is the one that I use in the clinic, but I have seen other providers or clinicians prescribe Premarin for other people. The cream is very nice in that it is affordable, it is easy and simple, there's very, very little systemic, like negligible systemic absorption, and like I said about all those symptoms, they can help benefit that forever and ever and ever. So you can die with your vaginal estrogen should you want to. There's people who have had breast cancer or other medical conditions, blood clots, what have you, that are able to get benefit from vaginal hormones of some kind. This cream's the usually more cost-effective version. However, this is July of 2026. When I started at the practice I'm at now, our vaginal estradiol cream, the generic Estrace, was $7 for a 42.5 gram tube. Then sometime in the last year, it went up to $12, which is not that bad. Thinking if you're on a maintenance regimen that lasts 20 something weeks, 21 weeks, not bad if you're using it twice a week, I should say that. But now it's over $30, which for how long it lasts if you're on a maintenance regimen, which I'll get into, is still pretty reasonable, but it just kills my heart knowing how much the prices have gone up. Anywho, for these, there may be slight differences depending who you see as a prescriber and which one they choose to use. But in general, you may be asked to do a loading dose where you use 2 grams or so nightly for 2 weeks, and then you drop down to a maintenance dose where you use 1 gram twice a week. I've had women tell me they don't love to do more than 1 gram because it gets even more messy. And I've even had women who they just start doing twice a week, maybe 3 times a week, and they don't do the loading dose. And that's generally fine. You're just going to get the benefits a little later on, a few weeks, than you may would if you did the loading regimen, if that makes sense. These creams are usually very well tolerated. I've never had a patient stop because of irritation or a side effect of the medicine or something like that. But 2 things they tell me: they hate the applicator. Everyone does, I think. So most people don't use the applicator. They'll just put it in with their finger or fingers. And as Rachel Rubin would say, I tell people to rub it in like sunscreen. But people do not like the messiness of it, which I get. I tell people to use it at bedtime before they go to sleep, or after any intercourse if they're going to have any. And I do like the flexibility of the cream. You aren't just putting it one spot, but you can rub it in and put the cream in a few different locations in the genitourinary area, urethra, clitoris, what have you, if you have irritation. But yeah, the messiness is why a lot of women don't adhere to it when they're talking to me in follow-ups and want to switch to the tablet version or the inserts, which is what I'll talk about next. The inserts are also estradiol, so that's nice, and the thought process of prescribing it is pretty much the same. You may do that loading dose and then 2 times a week after that, but women tend to like this a lot better because it's just inserting with the little applicator 1 tablet vaginally at the back of the vagina, and it's pretty much forget it because you're going to go to bed afterwards. I've also had women prefer this. Maybe they use the cream at home, but if they're going to travel, they like to take the inserts because they're not afraid that the cream will make a mess in their suitcase or whatever. So a few nuances there. The inserts are a little more expensive than the cream, so there is a cost increase, but for a lot of women it's not dramatically more. It's not like twice as much, whereas when the cream was cheaper there was a pretty significant price increase between the two. The benefits are about the same, it's just not as flexible. Versus the cream, it's a tablet, so it just sits in one spot and it will slowly dissolve after a film's created vaginally. So that's a really good option for people. One insert that I don't use a lot, but the people who are on it really like it. It's Intrarosa, so that's the brand name. Prasterone is the more generic name. It is DHEA, and again, it's local effect. It's not getting absorbed systemically a lot, so I'm not worried that you're going to get pimples or your testosterone's going to be too high or what have you. But the DHEA vaginally is going to break down into the androgen and estradiol components. So you may get some additional benefit having the androgen there as well, which is really nice. I've had a couple of women who either did not get full benefit, maybe they were still having pain with intercourse, something like that with the estradiol itself, and we tried that. Often if people have insurance, we'll have to do some kind of prior auth where it's like, okay, you failed this and this, now maybe they'll cover it. But I will say if they don't, it can be kind of costly. It's on the same prescribing schedule, like twice a week or so, as the other options I've already mentioned. So when you break it down pill to pill, sometimes it can be affordable, but cash pay I've seen anywhere from $60 something to $160 something for a 30-day supply, and that's just a lot for some people. It's not pocket change, I'll say that, but when I have had women use it, they have thought it was really nice. And it's really just like palm oil and DHEA, so there's not a lot of other ingredients that I think many women would be irritated by. Obviously it is going to have a messiness component to it as well, but it's pretty nice. One option I alluded to in the last video is Estring, not something I have done in the office, but it's a vaginal insert that will sit around the cervix and like the vaginal vault area, and unlike Estring, which I mentioned in that video that has systemic effects and local effects, this is a much lower dose than the Estring, so you're not going to get the systemic level benefits. It's just going to be local, but again, good sitting and forgetting for 3 months. So something where if adherence is a concern and it's affordable, or say someone's in an assisted living facility and they can't mobility wise do all the vaginal hormones, and obviously the staff probably aren't going to want to do that either multiple times a week to prevent UTIs or other super important things, we may be able to just say, hey, come back every 3 months and we can change it in the office, and then you're good again for 3 months. So very easy peasy. So I hope those are some helpful options. Trying to think of common questions otherwise women will ask me. Because there's really little systemic absorption for these, it's not something that I'm worried about if there are other breast cancer history, blood pressure issues, migraine issues, things like that. So I feel very confident that most people will tolerate this really well. Theoretically, if someone has had genitourinary syndrome of menopause for a long time and the tissue's pretty atrophied, pretty thin, you could get a little bit more systemic absorption in that initial period. So one time I have had a patient tell me when they started they got some breast tenderness, even though it's vaginal. And that is what I was talking to her about. But yeah, I hope this is helpful. Drop any questions you have below. Next time, I think our video is going to be about progesterones and progestins for like endometrial protection and sleep and stuff. So stay tuned for that video.